present the activity we have in the south of France, in Marseille. You see the hospital where I'm working, and I will discuss with you the reconstruction of the knee. And first, we have to have then an optimal shape of the prosthesis, and to reconstruct the femur, the femoral part, we have to have a stem to be round and curved, and the tibial stem right. You see the aspect of the link prosthesis we can use. There's other prosthesis also, and especially the upper part of the femur, which is curved and very important, because when you have a straight stem, then you can break the allograft. And you see in the tibial place, when you reconstruct the upper part of the tibia, you see that until the lower part of the tibia, then you have to have a straight stem. What sort of allograft then we use? It's a normal allograft. We don't need a ABO or rhesus group. The only important thing is to have a good size of the graft, but always remember that bone, that there is no vascularization, then the antibiotic cannot penetrate directly in the bone, and if there is an infection, you have to remove the graft. And there is no bone formation inside the grafted bone, so you need to use a cement to fix the allograft. The advantage of this activity is to have no lever arm, good periosteal formation, and new bone reconstruction. You see on the left side, total knee allograft with the femur, the tibia, the patella, and the tendons. When we use a bone allograft, you can take off what you need, and then only after you put the allograft on there, you reconstruct the lower part what you have taken off, and you have then easy reconstruction. You see the bone bank we have in Marseille. It has been built in 1978. On the upper part, you see that there is the bone bank, and we have made, you see, around 790 massive allografts. And what is the follow-up with this allograft? We have most of the time good integration of it, and if we want to have a better one, we have to surround it with autograft. But you have to know that when you graft a cortical bone, the vascularization of the bone is only superficial. Then you see the reconstruction of the lower part of the femur with link prosthesis and surrounded with allograft. You see our statistics. It's around 168 massive reconstruction of the lower part of the femur, especially in tumoral disease. And you see that we can reconstruct the whole femur and the lower part of the femur and upper part of the tibia. In some different cases of tumoral surgery, like in this case of juxtacortical osteosarcoma or for chondrosarcomas, you see you can take off the whole femur, or far from the whole femur. You see the upper part is allograft, the lower part is the recipient bone, and with already prosthesis, a small one, reconstructing the knee, with also osteogenic sarcoma of the whole femur, or chondrosarcoma of Bethel-Hagen, where you see good functional results, even with massive reconstruction of the lower part of the femur. If you have sepsis on reconstruction of with prosthesis, you can take off the spacer. I don't like to use a spacer, and reconstruct the upper part of the tibia, you see, with a centromedullary long stem and a plate to fix the junction between the two. The problem is to know if we use one or two prostheses when you have to remove the whole femur. In that case of chondrosarcoma of the whole femur, we put two prostheses, one at the upper and one on the lower part. But you see, in that case of the sarcoma treated 26 years before with a long stem prosthesis and allograft, with a fracture of the allograft, we reconstructed with a massive femur without prosthesis. At the upper part, the femoral head was exactly of the same size than the acetabulum, and then we can put the femoral allograft directly in the acetabulum. When we have to make numerous operations, most of the time it's because of loosening of material or sepsis, then we have to use to take off everything, and don't lie to use a spacer, because after some days you have a decreasing of liberation of antibiotics, and then I prefer not to use anything and to take off everything and put only and reconstruct the bone when the sediment rate is lower than 20, the PCR lower than 5, there's nothing, no more inflammatory aspect, and wait 2 or 3 more weeks. And in traumatologic cases, like we see a lot in the south of France with a lot of motos, and sometimes they lost on the road some part of the bone of the joint, then we have to reconstruct it, and you see in that lateral case it was also a prosthesis. You can reconstruct it with an allograft, and you see some years later you can take off the stem and you have a good fixation between the upper part of the femur and the lower part of the femur, which is the graft, and you can use only a small allograft. Most of the time the results are good, and it's only to see the advantage of reconstruction with an allograft, with the early loading, the rapid joint mobilization, with the normal mobilization, the good muscular fixation. Most of the time, you don't need to use the autograft surrounding the junction, but if you need it, you can do it. In that case, it's a bit too much. And you increase all the time the bone mass. Thank you very much for your attention.